So this morning we are privileged to have Dr. Tianjin Lee to give us a general or broad overview of systematic reviews and meta-analysis. But before we start, a few words about Dr. Lee. Dr. Lee is an associate professor in the Department of Ophthalmology at the University of Colorado Anschutz Medical Campus with a secondary appointment in the Department of Epidemiology at the University of Colorado School of Public Health. Dr. Lee's research goes out to develop, evaluate, and disseminate methods for comparing healthcare interventions and to provide trustworthy evidence for decision-making. Dr. Lee has worked with COCHRANE for 18 years, taking on many leadership positions. If you are familiar with COCHRANE or COCHRANE reviews, then anytime you hear the name COCHRANE, you know we are talking about systematic reviews and meta-analysis. So she had played leadership role in that for over 18 years. She is currently the director of the COCHRANE Eyes and Vision USA satellite. She served as an associate scientific editor for the second edition of the Cochrane Handbook for Systematic Reviews of Intervention and was the 2019 recipient of Cochrane's Anderson Award. Outside of Cochrane, Dr. Lee serves as an editor-in-chief for the journal Trials, a statistical editor for Annals of Internal Medicine, the review editor for JAMA Ophthalmology, a section editor for book Principles and Practices of Clinical Trials, an author and editor for textbook for epidemiology, second edition, among others. If I have to say more about Dr. Lee, that will take a substantial amount of our time, and I don't want to do that now, so we can save the time for that. She is the president-elect of the Society for Research Synthesis Methodology. So, Dr. Lee, we thank you so much for giving us time to do this two-day workshop. You can show your appreciation to Dr. Lee, and then over to you, Dr. Lee.
Thank you, John, so much for the nice introduction. And it's so nice to be here with everyone this morning. And I saw in the chat, some of you are waving to us from Peru. So if you want to tell me where you're from in the chat, that will be very nice. It's hard for me to see the slides and the chat at the same time. So if you have any questions, feel free to just unmute yourself and speak up. You don't need to raise your hand, just unmute yourself and speak up. And I will try to look at the chat whenever there's an opportunity. And I'm also going to ask John to help monitor the chat. If there are questions about any content of the materials, please raise those questions. So I want this to be as interactive as possible. And I gather from John, many of you are researchers, investigators, and faculty members in various capacities. So hopefully, you can apply some of the methods I'm going to cover in the next 2 days in your own work. So let me start by sharing my slide. You should have access to the slides. Okay, so this is, I'm going to start by basically introducing to you what a systematic review and meta-analysis is. And here's the program for the next 2 days. This session is going to be like a little bit shorter than an hour. We're going to take a break. And then you will hear another lecture about framing a research question for a systematic review. Then we're going to send you to breakout rooms, and we have another faculty joining us, Riaz Qureshi, at 12:30 your time to facilitate the small group discussion about framing the question. We're actually going to send you to work on some questions, and then we'll bring you back to the main room, and for each of the group, we'll ask you to report on your sort of reframed research question. We do have some homeworks for you today. So we want you to watch the online lecture about searching for trials. So that's something actually many of the graduate programs don't teach you while you're a student, but it's so important. And these are pre-recorded lectures that are very short. So each part is about 5 to 10 minutes, so you won't take more than 40 minutes for you to watch all 3 parts of the session. It gives you a very higher level overview of what the how to develop a search strategy and what are the key steps and how you need to document the search strategy. And I cannot emphasize enough the importance about this lecture, because when I serve as a journal editor for many journals, one of the main reasons that I reject systematic review manuscript is because the search is not comprehensive. So that will be this morning. And tomorrow morning, we will reconvene and I will give a lecture on assessing the risk of bias in randomized trials. And that will be based on the Cochrane tool for assessing risk of bias, the 2nd edition. And then you will hear more statistics, introduction to meta-analysis. And I promise you there won't be any Greeks on any of my slides. So hopefully we'll be at a very high level overview of what the analysis involves. And after the sort of the in-person session, we do have another online lecture recorded by Riyadh, who is going to join us later today on abstracting data for systematic reviews. So that really shows you a little bit more about how to do it, sort of thing. Because given the time we have, I will cover more like the key steps on higher level processes and principles to follow. And then the online lecture will show you more about how to do it. All right, so that's the program. Without any further ado, let's dive into what is a systematic review. So the key messages are: systematic review uses explicit methods to identify, select, praise, and synthesize results from similar but separate studies. So those 4 verbs basically summarize the key steps of how to do a systematic review. First of all, you have to identify all the literature out there. You select from that pool and appraise them in terms of the quality, risk of bias, and then synthesize the result. And the synthesis sometimes involves a meta-analysis, which is the statistical analysis of a collection of results from individual studies, which is an optional component of a systematic review. So don't equate systematic review with meta-analysis. Meta-analysis refers to the statistical component of a systematic review, and many systematic reviews do not have any meta-analysis. And the Cochrane library, as John mentioned, is the main product of the Cochrane. It's the single best place to find independent, high quality evidence for healthcare decision-making. We hear some background noise. So if you have a question, please speak up, but otherwise, please go ahead and mute yourself. Information about health and healthcare is everywhere, okay? But how do you know if one intervention works better than another, or if it will do more harm than good? Here are some news headlines that we encounter every day, in social media, in news channels, and they sometimes, a lot of times actually, conflict with each other. So here is an example: eating breakfast may not help you lose weight, study says, right? And here's another: peanut allergy. Early exposure is key to prevention. For ages, we were thinking, if the young children are susceptible to peanut allergy, we would withhold peanut from them. But actually, that's the wrong strategy. And then, for years, I have been operating under one, glass of wine is good for you every day. But now this study shows there's no healthy level of alcohol consumption. So all these headlines are based on systematic reviews. How do we summarize the results from multiple studies? So here's an experiment by dropping a cat. How many times they land on feet and land on head. You can count the results in terms of the direction, right? So I would like to quote from, the former senior deputy editor for Annals of Internal Medicine. She said the hundreds of hours spent conducting a scientific study ultimately contribute only a piece of an enormous puzzle. The value of any single study is derived from how it fits with and expands previous work, as well as from the study's intrinsic properties. Through systematic review, the puzzle's intricacies may be disentangled. So I think she summarized very elegantly, what is the role of systematic review in scientific investigation, right? So you want to build your research on everything else that people have done in the past. So you should do a systematic review to summarize what has already known. And from there, you can also identify research gaps and future research needs. So systematic review is really a methodology where you can piece all these things together. Systematic reviews address research questions Here are some typical clinical questions. For example, is yoga effective for improving health-related quality of life, mental health, and cancer-related symptoms in women diagnosed with breast cancer? Is early epidural as effective and safe as late epidural for women in labor? So both questions are about health and healthcare, and both of them are about effects of interventions, right? The first one is about yoga. The second one is about, when to give epidural. And those questions can be tested in randomized controlled trials, right? When you have multiple randomized controlled trials on the same question, you could summarize them in systematic reviews. Here are two more questions. Does IVF increase the risk of breast cancer? Does formaldehyde exposure increase the risk of leukemia? So unlike the first two questions, these two questions are slightly different. They're sort of looking at the harmful effect of exposure or harmful effect of intervention. Right? So in this case, you may want to go beyond randomized controlled trials to look for observational evidence and summarize them to answer these questions. Systematic reviews can also be used for questions outside of medicine or healthcare. So here are some examples. Does spending more money on schools improve educational outcomes? Do women or men make better leaders? Does sexual orientation of the parent matter? Are fathers more likely than mothers to treat their sons and daughters differently? Is job absenteeism an indicator of job dissatisfaction? So for every single question I'm showing you here, actually there is at least one systematic review. So as you can see, systematic review should really be perceived as a methodology to answer a predefined, well-formulated research question. So let's coming back to the first example about yoga for women diagnosed with breast cancer. There's a Cochrane systematic review published in 2017. So in this systematic review, the authors found 24 studies, and these are all randomized controlled trials that involved over 2,100 women. And they searched the literature up to January 2016. And they found that the yoga was more effective than no therapy in improving quality of life and reducing fatigue and sleep disturbances. They also found that yoga was better for reducing depression, anxiety, and fatigue in women when compared with psychosocial or educational interventions such as counseling. They found no evidence of serious risk of yoga among women with a diagnosis of breast cancer. So these are their key findings. They also translated like in a more lay language term for the public. So what does this mean? Their findings indicate that women with a diagnosis of breast cancer can use yoga as supportive therapy for improving their quality of life and mental health, in addition to standard cancer treatment. So how did they reach this conclusion? Here is the first, after you frame that question very specifically, and then you would look for all the literature. So they searched, a couple of databases, identified, 428 records from database searching. And then after they remove duplicate, they end up with 307 records. So if you follow through this flowchart, you will see how they selected the studies and why some of the studies were excluded with reasons on your right-hand side. And by the end of the day, they found 52 full text reports reporting on 24 studies. So they included 24 studies in that systematic review. However, only 23 of them were included in any quantitative synthesis that refers to the meta-analysis, right? So a systematic review can definitely include more studies than the number of studies that can contribute to meta-analysis, and we will talk about reason why. And as you can imagine, not all the studies may measure the same outcome, and your meta-analysis is based on a particular outcome. The next thing very critical for a systematic review is sort of the critical appraisal. We call this risk of bias assessment of the included studies. So here you have the 24 studies, and these are the items for risk of bias assessment. They assessed whether random sequence was adequately generated, and then you have the color-coded rating. So the green means low risk of bias for that domain, yellow means unclear risk of bias, and red means high risk of bias. So we call this like a traffic light plot, where you can sort of eyeball it and visualize it and give you a sense of whether the quality of evidence is high or not. So I would say based on this figure, it looks like most of the studies are either at low or unclear risk of bias for most of these domains that the authors selected and assessed. So tomorrow we will spend an hour on the risk of bias assessment. So I dive deeper into how you reach the judgment. But a critical component of a good quality systematic review is have this risk of bias assessment. And this risk of bias assessment will inform you how much confidence you have in the finding from the meta-analysis or systematic review. So as I said, when appropriate, the next step after you praise the quality of the evidence, you want to put them into some form of synthesis. Meta-analysis is just a statistical component of a systematic review. So this is how a typical meta-analysis is presented in a systematic review article. And we call these a forest plot. So you may have seen this before, and I'm going to walk you through. So here the comparison is between yoga versus no therapy. And the outcome of interest is health-related quality of life at short term. And like health-related quality of life, they're generally measured by instruments, right? By patient-reported instruments. They might be using different ranges, different scoring systems, and the different instruments, basically. So what the authors, because of that, the way you're going to summarize when you're using different instruments measuring the same underlying construct is to use a measure of association that's called standardized mean difference. So that's basically how many standard deviations one intervention is better than the other. Another example I can give you is you can imagine for IQ measurement, right? Most of the time, we're talking about standard deviation. How many standard deviation, is a particular individual above or beyond the population average? So that's the standardized mean difference, which is the measure of association. And then you have the result from each individual study. So that's the mean and standard deviation from each arm or each intervention group from that particular study. So this is a randomized control trial with 7 individuals where you have the mean and standard deviation for the yoga group and the mean and standard deviation for the no therapy group. And then you have the standardized mean difference from that study. So that's basically the measure of effect from the first study. And this is depicted here with this, estimate in the 95% confidence interval. And as you know, for any continuous measure, when the confidence interval covers the null value of 0, which means there's no evidence of a difference between the 2 intervention groups. So that's how you read the plot for the first part. And then this little diamond here, which is a combined summary effect from these 10 studies. So this is what you're going to pay attention to, the diamond underneath the plot, which summarizes, which is a weighted average of the individual study results from these 9 studies. So altogether, we have 354 individuals under the yoga treatment, 321 under no therapy treatment. The combined estimate is 0.22, has a confidence interval that doesn't cover the null value. So this is a good example that shows you that meta-analysis can increase the precision. It has a better power to detect an effect when it exists. Because if you look at all these individual study estimates, except one study, almost all these studies have a confidence interval that covers null value, right? So none of them is statistically significant except this one study. However, when you combine them together, we have a combined summary effect that is statistically significant. And then you have this column of the weight. So the weight is basically the relative weight that each study contributes to this combined summary estimate. So we'll talk about how the weight is derived tomorrow, but basically, as you can imagine, the weight reflects how much information each study has, right? Each study contains. The bigger study will contribute more weight to the combined summary effect compared with the smaller study. So for example, if you look at this study, the largest study, right, we have about 200 individuals in this study contribute 23% of the weight compared with the smallest study, which only contribute 2.7% of the weight. And underneath the plot, we have all these heterogeneity estimates. And we will spend some time tomorrow to describe to you what these estimates mean. So any questions so far about how to read a forest plot? So far, so good? Okay. If you have any question, please just unmute yourself and speak up or type your questions in the chat box. So once you have done all these analysis, again, as I mentioned, this analysis is by outcome. This particular review, they do have health-related quality of life short-term, as well as a separate analysis of health-related quality of life at long-term. They also have other measures such as depression, sort of psychosocial measures. And then you can summarize them in this what we call like summary of findings table. So if we focus on what we have looked at just now, the health-related quality of life at short term, here's how many studies and participants contributed to that analysis. Here's the 0.22 standardized mean deviation we just looked at. Here is the certainty of evidence. So it's moderate because it's downgraded for risk of bias, for imprecision, for other reasons. So we won't have time to talk about the grade sort of framework for rating the certainty of evidence, but this becomes actually very useful for guideline developers, because by the end of the day, you want a take-home message about how much confidence I have in that estimate. So now coming back to summarize, what is a systematic review? So systematic review focuses on a specific question, and then it uses explicit pre-planned scientific methods to identify, select, praise, and summarize similar but separate studies. So the identify part is the flow chart I showed you. You search multiple databases and try to be as comprehensive as possible. And from there, you select the relevant literature for your research question. You praise the literature using the risk of bias tool, which we'll dive into tomorrow. And then you summarize the findings. And when appropriate, that summary may contain a meta-analysis. So
we have a question in the chat.
Oh, sure.
Asking you if you can slow your pace down just a little bit.
All right. So of all the review articles, only a subset of them should be called as systematic reviews. Most of the reviews are just traditional narrative reviews. They're not systematic. And from there, only a subset of those systematic reviews may contain meta-analysis, which is the quantitative summaries of the results from individual studies. So that's how you would, don't equate systematic reviews with meta-analysis, because many systematic reviews do not have any meta-analysis. In terms of the steps in completing a systematic review, the first step is to prepare your topic. So to formulate research questions that can be addressed by systematic reviews. We will spend another hour after this section to talk about how to frame a research question. That's probably the most important step of the whole process. As you can imagine, if the research question is yearly framed, and everything else from that point onwards would not be suitable or would not be appropriate to answer that research question. After you frame the research question, the question will help you to design your search strategy for studies. And you will have to define your eligibility criteria. So which studies will be included or excluded, and you search for relevant studies. And this step we recommend, and everyone else recommends, you should work with the information specialist. These are like librarians who have experience in developing searches for systematic review. So don't do it by yourself. This is certainly a step you should work with someone else, okay? And we have a recorded lecture to show you the principles of developing a comprehensive search strategy. So I encourage you to watch it. And then when you are in a conversation with information specialists or librarians, you will be able to at least highlight the things that you want them to help you with. So from the search results, you're going to screen the studies to identify that those that meet your eligibility criteria. And from there, you will have the included set of studies. And you collect the data from that set of included studies, assess the risk of bias from those studies, construct evidence tables, and when appropriate, you would analyze the data in a meta-analysis. So all the systematic reviews can include a narrative or qualitative synthesis, but very few, some of them may also include a quantitative synthesis, that is meta-analysis when appropriate. And then you will assess the strength of evidence and write up the report. So these are the key steps in completing a systematic review. And on average, it takes at least 18 months from the first step to you're able to put together the first draft of the report. So it is certainly not something you can do it over a weekend, okay? So, this is true, like I have been in elevators hearing people saying, hey, I'm going to do a systematic review this weekend. I think, oh gosh, good luck with that. So don't underestimate the time and resource requirement for conducting a high quality systematic review. And the other thing is, from the screening of the study's abstracted data, we recommend that 2 people work in pairs. So usually is a clinical, is someone who has the domain expertise working together with someone who knows about the methods. Like when you're screening studies, that needs to be done in duplicate. When you're collecting data and assess the risk of bias, again, we want someone else to check your work. So it's better to have 2 people completing these 2 steps. So that adds time again. All right, so why systematic reviews are important? You probably have all seen the evidence pyramid where systematic reviews are placed on top of other forms of evidence. I think it's important because it aims to capture all the relevant high quality evidence through the comprehensive search. So it may provide a pooled estimate of effect from all the studies that increases the power and precision. So remember the example I showed you, the forest plot, except when you're looking at individual study result, only one of them is statistically significant. But when you are combining all of them together, you have the diamond, the summary effect that is statistically significant. And systematic reviews involves the analysis of the risk of bias of included studies and the certainty of evidence. So that will place your results in the context. If you're mixing apples and oranges, or if you're putting the good studies together with the bad studies, how much confidence do you have in the overall result? It serves as a basis for most credible guidelines. So, the concept of a systematic review is really like putting all the studies through a funnel where you will be able to analyze all of them and put them in a more organized fashion and be able to interpret the results, which can inform policies and clinical practice. So where does evidence synthesis or systematic reviews fit into the process of the knowledge translation? Many of you must be very familiar about, sort of the primary evidence generation step. We talk, those are like clinical trials, observational studies, where you collect data from human subjects, right? So those are primary studies where you collect data directly from human subjects. And evidence synthesis or systematic review is really the next step. It's a secondary analysis of all these primary studies where you put similar studies together when they are all relevant for a research question. And then this synthesized information or knowledge is going to inform clinical policy, such as practice guidelines put together by professional societies. And from there, we hope you can apply the evidence-based healthcare by integrating the best available evidence, the clinician's expertise, as well as patient values. So evidence synthesis really serves as the bridge between the primary studies to the application of knowledge at bedside. Any questions so far? So I hope you have a good sense of what systematic reviews is about. We will dive deeper into meta-analysis tomorrow and the risk of bias assessment tomorrow. Any question? All right. So in terms of meta-analysis, I have said this many times, and I hope that will be one key take-home message for you when you walk away from the session after tomorrow. So meta-analysis is really an optional component of a systematic review. Here are 2 definitions. I like the alternative definition better because it says it's a statistical analysis which combines the results of several independent studies considered by the analyst to be combinable. So I think putting the analyst in the definition is very important because you may decide the studies are too different and it's not worth combining them, right? So as the data analyst, you have to say whether the studies are similar enough that you can justify a meta-analysis to combine them. Let's review a forest plot. So here we have another forest plot based on data from a review on I think is the light reduction for retinopathy of prematurity. Here we have 5 studies, okay, 5 studies, and each study shows its result in the 95% confidence interval. For this particular analysis, the measure of association is risk ratio. So risk ratio or relative risk is basically the risk in the intervention group divided by the risk in the comparison group. We have the line of no effect around 1, because when the relative risk or risk ratio equals 1, that just shows you there's no evidence of an effect between the intervention and comparison group. And then you have the estimate and the confidence interval for the meta-analysis showing as a diamond here. And then you have the scale down here, and you label the scale and the direction which favors the light reduction or favors the control. Okay, you must have noticed that the size of the squares are very different from the studies. The size of the square is proportional to the relative weight that each study contributes to your meta-analysis. And I'm going to stop here and ask you, by looking at the size of the square, can you tell me which study contributes most of the relative weight to your meta-analysis?
Reynolds, 1998.
Yes. Yeah. So Reynolds is the most precise study, and it contributes most of the weight to the meta-analysis, right? So the second question I'm going to ask you is, by eyeballing these 5 studies, do you feel like the study results, the results from these 5 studies are relatively consistent, relatively homogeneous? Are there any outliers here?
Cybert, maybe?
Why saying so?
Because it's showing risk ratio distribution only on one side of that neutral one.
Yeah. So pay attention to the 95% confidence interval, right? Because the center of the square is where the point estimate is. It does show it favors the control. However, the 95% confidence interval crosses the null value, right?
Mm-hmm.
So when the 95% confidence interval covers the null value, you know that when you're repeating the experiment, the same experiment over and over again, sometimes will be over this side, other times will be over the other side, right? So that shows you the random error in that study, right? So I would say by eyeballing the studies, every single study is bang on the null value, right? So the results are very homogeneous or consistent across the 5 studies. Would you agree?
Okay, now that's explained.
Yeah, it makes sense, right? So this is a good example where the study results, at least by looking at these numbers, they're quite consistent. And then, putting them together, a meta-analysis makes sense, right? But on the other hand, I will show you more information about these studies tomorrow. And, one of the study was done, nearly 40 years before the other studies were done. And then, as you can imagine, the study population might be different. The intervention might be different over, across 40 years. So once you know about the characteristics of those trials, you may have a second opinion about whether it makes sense to combine all these studies together, right? So that is the part that is very important for a meta-analysis. We call it like a qualitative synthesis, basically to decide whether it makes sense to put these 5 studies together. And the numbers tell you something, but not everything that you need to know about the trials. You want to know, when the trial was done, how it was done, what was the risk of bias, what was the population studied, what were the interventions compared, right? So all those information will come from all the other pieces of the data you're going to collect from those studies. That will inform you whether a meta-analysis is sensible, okay? So a framework for synthesis.
Sorry, there's a question on.
Sure.
Yeah, there's a question on the chart. How do you assess the homogeneity based on that?
Yeah, so the assessment of homogeneity, I was trying to allude to that. Let me see if I can go back. There are 2 types of assessment of homogeneity or heterogeneity, however you want to word it. One is based on the study characteristics, right? We call that qualitative synthesis. So it's based on the method we look for methodological heterogeneity, and we also look for clinical heterogeneity. So the methodological heterogeneity refers to the study design, refers to the risk of bias. And then the clinical heterogeneity really refers to the population studied, refers to the intervention comparison characteristics, refers to the outcomes being assessed in those studies. So those are the qualitative synthesis. And then there's the quantitative synthesis of heterogeneity. And then the first step of the quantitative synthesis is to plot all the results on a forest plot like this one. And you can eyeball whether the studies are very homogeneous or heterogeneous in terms of the effect estimate. And then we do have statistical measures that can quantify the amount of statistical heterogeneity, which we will discuss tomorrow, okay? So the take-home message is that there are two types of assessment for homogeneity or heterogeneity. One is purely qualitative and one is quantitative. And a good systematic reviewer and a meta-analyst should do both. Okay, so you should do both. You rely on your understanding of the literature to assess the methodological and clinical heterogeneity. And then there are statistics to help you to quantify the amount of statistical heterogeneity. So we will talk about that in depth tomorrow, but just to give you a preview of the different types of assessment. A framework for synthesis, a synthesis tells us about the direction of effect or association when we're talking about exposure to harmful factors. It tells us the size of effect. It tells us whether the effects are consistent across studies. We touched upon that already, the question about homogeneity or heterogeneity. And we also want to know what is the strength of evidence. So the strength of evidence also relies on the risk of bias assessment, relies on how directly the evidence or the population studied is applicable to the population where you want to generalize the knowledge to. It also relies on, sort of the precision of your estimate. Okay. So what meta-analysis can help you do? First of all, when you combine all these studies together, you will be able to determine whether an effect exists in a particular direction. You can obtain a single summary result, remember the diamond underneath all the, sort of the forest plot. And you could use a meta-analysis to examine the reasons for different results among studies. So imagine if those 5 studies were all over the map, you want to understand why they're all over the map, right? So there are statistical methods to help you to examine the differences between the results. And we will talk about them briefly tomorrow. So I saw another question in the chat. Being a biologist and being clinical bench worker, I need to see the strategies with an example and compare my data that where we stand. Yeah. So that's a very good point. That's exactly where, sort of by putting all the studies together can help you at least to visualize and to be able to see where your results, how your results and how your results fit into the bigger picture of the body of literature. So the justification for combining results, the studies have to be estimating in part or in whole a common effect. The studies are addressing the same fundamental biological, clinical, or mechanistic question. So let me show you the example to illustrate that point. So here is a research question. What is the effectiveness of face masks in reducing the spread of respiratory viruses? So you would think that question is relatively simple, right? Like we all wanted to know, like 2.5 years ago when the COVID pandemic hit us. However, if you dive a little bit deeper into the question, there are different types of the masks, right? The N95 works completely differently from a surgical mask. And then their effects in reducing the spread of, respiratory viruses is very different. There are different types of participants. Are we talking about healthcare workers who have, a lot more exposure than an average healthy individual? There are patients who are infected. There are vulnerable populations, and then lastly, healthy individuals. So you can ask that same question in this different population, and you can imagine, dependent upon the population, you're going to have a very different result of whether face masks are effective. And there are different types of settings. You can put people in the laboratory. there could be hospitals and community, and then all of this can be tested during an outbreak or during, or during, the peak of outbreak or when outbreak fades a little bit. And there are different types of viruses, like I did not specify what type of viruses, but I'm sure you're thinking about COVID. And there are different types of study design. We have randomized control trials, non-trials, animal studies, and mechanistic studies. So these are all like, these different aspects of the research question, whereas you can imagine any variation in these components, if you think thoroughly, you're going to get a different result. So different result, I mean, let's say a relative risk of how effective face masks are in reducing the spread of the virus, you will have a different result by varying any of these elements. So when you're putting all these studies together into a meta-analysis, you have to decide and rationalize whether it makes sense, right? So I would say probably it does not make a whole lot of sense to put all the studies tested during the COVID outbreak among the healthcare workers with that among the healthy individuals, because the exposure level is way more higher among the healthcare workers, right? So in that case, a meta-analysis putting all these studies together does not make a lot of sense. What you could do is to separate your meta-analysis into subgroups. We call that subgroup analysis, where you will have separate analysis for different population, right? And you can also have separate analysis for different types of the masks. So that's how you think about, oh yeah, it doesn't make sense to put all of them together, but I can see subgroups of participants, subgroups of intervention comparison where it does make sense. Is that question not directional? I'm not sure I understand that, Chad. You may want to speak up.
I was looking at the word reducing and spread in the same question.
Yeah. So you don't have to make your question directional, right? This is what we hope they do. So you could just word your question, what is the effectiveness of face masks in the spread of respiratory viruses, right? So you don't have to have that direction. All right, does it make sense to you that, this seemingly quite straightforward question, actually there are many, variations in how each primary study could be designed and carried out in addressing that bigger question, right? So when you're analyzing this data, you have to decide whether they're similar enough to be put together in the same meta-analysis. So now I'm going to ask either John or the facilitator to bring out the poll question. How many studies do you need for meta-analysis? Can we bring up the poll question number 1? Yeah. So you only need to answer the very first.
So yeah, the questions are there, yes.
Oh, the way it's set up, you have to answer all of them. This should be set up as 4 separate poll questions. But anyway, if you can type your answers in the chat or just unmute yourself and shout out, how many studies do you need for meta-analysis?
Tianji, can they maybe just answer the first part, question 1, and then once you come to question 2, they answer that also?
You cannot submit, that's the problem.
Oh, you have to respond before, okay.
So if you can just copy paste those questions into separate ones. So I see a lot of, it depends. I love it. So, the joke is, if you're an epidemiologist, the answer, it depends, is always correct. I think that is the correct answer, it depends. But if you, how many studies do you, what is the minimal number of studies do you need for meta-analysis? If I were to rephrase the question,
Could I answer that question? I mean, if you were the way you just rephrased it, I would say more than 1 is good enough.
Yes, you are absolutely correct. So the minimal number of studies you need for meta-analysis is 2. Because remember, meta-analysis is a weighted average of the results from multiple studies. And to take an average, you need at least 2 studies. So you will need at least 2 studies for a meta-analysis. Okay. All right, so let's move on.
Sorry, and then I also have a question. If the minimum is 1, or if the minimum is 2, it means that the time frame might be relative, because if I'm working with 10 articles, I wouldn't be spending the time like 18 months, like you said, like someone that is using 300 articles.
Yeah, so when you have when the evidence base is quite scarce, right? Like in the example you said, if there are only 2 studies, is it worth to do a systematic review and meta-analysis? And that's a question. It really depends on the context, right? You may decide that it's not worth the effort. And I have seen plenty of systematic review report that includes either 0 study, 1 study, or 2 studies, but the systematic review report is longer than those 2 manuscripts stacked together. So you may decide it's not worth the effort. On the other hand, doing a systematic review when the evidence base is very weak helps you to justify that new studies are needed. So systematic review will help identify the research gaps, and you can justify future restudies based on very weak evidence base. And as a matter of fact, many funders in European countries such as the NIHR in England, they will only fund clinical trials after you do a systematic review to show that there's really no study of the same kind that you would like to design and get funded, right? So there are different values of doing a systematic review, but when you have only a few studies, I mean, it won't take 18 months, hopefully. Yeah. So when to do a meta-analysis, when you have more than 1 study has estimated treatment effect or association, when the differences in the study characteristics are unlikely to affect the treatment effect, right? Remember the example I showed you about face masks, or when you're interested in investigating the specific differences. So I would say, when you're interested in knowing whether N95 works differently from surgical mask in the healthy population, in the public, you would include both type of study and do subgroup analysis to investigate that specific differences. And lastly, you will need the treatment effect to be reported, measured in similar ways, or when the data are available. So here I can give you an example. We have done many systematic reviews in eyes and vision related topics, and dry eye is one of the topics where actually there are many trials. For one of the dry eye topic, we included more than 40 randomized controlled trials, but we couldn't do any meta-analysis. The reason being every single study measures something differently. So one study could be using one instrument, another study using a different instrument. One could be measuring the symptoms of dryness, the other measures irritation. They're all measuring something differently. And another dimension you can think of is the time scale, right? Some could have measured after 7 days of using eye drops, others measured after 6 months. You have to think about whether the 1 week result is comparable to the 6-month result. So for many systematic reviews where you could have many studies, but you may not be able to do many meta-analysis because the outcomes are not measured and reported in the same way. When do you not want to do a meta-analysis? I mean, the famous saying or the criticism of meta-analysis, garbage in, garbage out. So meta-analysis is only as good as the studies in it. You have very tighter confidence intervals around the combination of the bias studies is worse than the bias studies on their own. If all the studies are really of poor quality, when you combine them, it's just very precise, but precisely wrong. Okay, and you should be aware of reporting biases. So reporting biases refers to the publication and reporting of outcomes and results, or even the whole study on the basis of the direction of the result, on the basis of the statistical significance, and on the basis of the magnitude of effect. So that's reporting bias. And also the other criticism is about mixing apples with oranges. They're not really useful for learning about apples, although they're useful about learning fruit. So a research question addressed by systematic review is usually broader than the research question in an individual study, right? So you have to think about, you have to accept to some extent these studies are going to be different. No 2 studies would look identical, right? You have to accept the differences are there. And then the question addressed by a systematic review can and usually must be broader than those addressed in the primary studies. All right. There's a question about slides. I think I shared all the slides ahead of time. You may have to reach out to John to get hold of them. So let me see, we're running a little bit short of time. So I will finish with this example. So this is whenever you hear any talk on systematic review and meta-analysis, this example came up. The methods for meta-analysis actually originated from the field of ecology, education, social science. It's not from medicine. So medicine really just borrowed the idea of meta-analysis. And it has not gained a lot of attraction early on until after, early 90s, and especially this seminal paper, where the authors looked at thrombolytic therapy amongst individuals who have had one heart attack already. So, and the outcome of interest is mortality. So it's basically to investigate the effectiveness of thrombolytic therapy amongst individuals who have had a heart attack. And the outcome of interest is mortality, okay? And then this is a cumulative meta-analysis. So each dot here is based on evidence accumulating up to that point. So the very first trial was done in 1960, the very first randomized control trial with 23 participants. And the point estimate, and again, the outcome of interest is mortality, in terms of odds ratio is about 0.5. It in favors of the treatment, although you can see, the confidence interval for that one tell is very wide, right? So it covers the null value, so it's not statistically significant. And then if you look at the second point here, so this is, instead of the result from the second trial, is actually a combination, a meta-analysis of the first two trials. So once you combine the first two trials together with the altogether 65 individuals, you also got a point estimate close to 0.5, but it's more precise, right? So if you keep going down, after the 10th trial was done, that was in early 1970s, more than 2,500 participants were randomized by that time. And the meta-analysis of those 10 trials showed a significant result. So thrombolytic therapy was effective in reducing mortality, and the odds ratio is about 0.75, right? And with a p-value less than 0.01. So that's a highly significant result, okay? However, we could have stopped over here had meta-analysis existed or being used in medicine and in healthcare field. However, we were not keeping track of the knowledge. We're not keeping track of cumulative knowledge over time. Look how many more trials were done. Another 60 trials were done from the early 70s to the 90s, with more than 48,000 individuals randomized to answer the exact same question, okay? Imagine what happened on the consent form. When you're signing a consent form, you're telling people, we don't know the effects of this treatment, you're contributing knowledge, to serve the public good. However, had we keeping track of the knowledge over time, we would have known the answer like 20 years ago, right? Without conducting another 60 randomized control trials, without randomizing another 48,000 participants. And if you look at the estimate, what happened to them, the estimate did not even shift a tiny bit. They're right around, 0.75 over time, although the confidence interval gets tighter and tighter. So that just shows you, the problem of not keeping track of knowledge over time. And on this side, you show whether the author showed whether the medical textbooks or review articles recommended thrombolytic therapy. So they were not recommended until meta-analysis were done. So the M means the meta-analysis. So multiple meta-analysis were done over time. So it's not until the meta-analysis have shown these results that the textbooks and the review articles started recommending thrombolytic therapy. So, we're not criticizing the people there because the meta-analysis methods was not really in existence and was not really used in healthcare back in the days. However, this is a very good example illustrating had we keeping track of information in a more systematic and comprehensive fashion, we would have known the answers way earlier than what happened in this example. All right. So that is, I'm going to skip the sessions about how systematic reviews fit into the guidelines, and you can just read through them, because I want to point you to some resources for conducting systematic reviews. So actually, independent authors produce most of the systematic reviews, included in any database, and Cochrane is a very big group as well. And there are groups interested in policy, such as the Agency for Healthcare Research and Quality in the US. In the UK, there's NICE, and in Germany, the EQUIC. And then also there are private businesses who conduct many systematic reviews. And we're going to skip that. So when you go to the Cochrane library, you will see this is the landing page. I would encourage you to try it now. Just put the Cochrane library in your Google and see what comes up and whether you have access. For most of the institutions in the US, you may need to access the full text of these systematic reviews through your institution logging, remote access. So in the Cochrane library, when I prepared the slides last week, there are more than 8,800 complete systematic reviews and more than 2,400 protocols. And then the Cochrane library also has a central registry of controlled trials. So if you're looking for randomized controlled trials for your research question, definitely search the Cochrane library, because there are like more than 1.8 million records in that registry. And then you can, the Cochrane library also publish editorials, special collections, and clinical answers. So these are their special collections. And of course, there's quite a few related to COVID-19. And I'm going to point you to two resources for to show you, like, every step of the way how to conduct a systematic review. So this is the Cochrane handbook for systematic reviews of intervention. You can get a print copy, or you can access the PDF copy, like online version, and it is free of charge. So if you just Google Cochrane handbook, it will take you to the handbook website, and you can browse the content free of charge. And the other very helpful resources is called these standards for systematic reviews, put together by the Institute of Medicine. Again, it's free of charge. If you just Google the book, and it will take you to the website to download the whole PDF of the book. And Cochrane reviews are put together according to very high standards, and this is the methodological expectations of Cochrane intervention reviews. Again, this is also free of charge. If you just Google it or click on the URL on this slide, it will take you to sort of a checklist of the things you should be thinking about and hopefully follow when you're putting together your systematic review. So here are the key messages. I hope I have showed you what the systematic reviews are. It's a methodology that can be used to summarize and synthesize results from similar but separate studies. It follows protocols, it follows very well-defined methods. And meta-analysis is just a statistical analysis of the results from individual studies. And I encourage you to browse the Cochrane library. So now we're at 9:30. So we're going to take a break and reconvene. Let me just go back to that, look at my schedule. So let's take a 15 minutes break and come back, and I will talk about how to frame a research question for systematic review, and then you will be sent to breakout rooms for group exercise, okay? All right, shall we restart?
Yeah, hello, Dr. Lee, let me just make one quick announcement then. Yeah. So if you are here, I mean, this is a 2-day workshop. We'll give you a certificate, but for you to get the certificate of attendance, you have to attend both sections, that is today and tomorrow. But to know that you have attended, there is a link there at the very beginning of the chat that you see that also in Slack for you to sign in. So if you haven't done that, you want to do that, especially if you need the certificate of attendance. All right, Dr. Lee, take over.
Right. Thank you so much. Welcome back. Again, I want to get to know you better, although we have very limited time together. If you can just say where you're from in the chat, and I would like to say hello back. So this session is about framing the question. So we have about 45 minutes to go through a lecture to just give you some examples and the things to keep in mind when you're framing a question for systematic review. And then, as I said, we will have Riaz Qureshi joining us, and we will send you to breakout rooms to work on your own questions. Your own questions I previously shared with John, and you should be able to download that. And I would encourage you to download that ahead of time. And I'm sure they can guide you to access the questions. And don't worry about, there are 6 questions, but we're going to send you to 3 rooms basically. So each of you only need to work on 2. So just make sure you have access to those. You don't need to do any prep work until the session starts. All right. So framing the question, again, I'm going to show you this figure repeatedly to remind you about the key steps in completing a systematic review. So by the end of 2 days, you will have to memorize these, and you will be able to describe to people what systematic reviews involves and what are the key steps in completing them. So the very step, as I said, probably the most difficult part is to formulate a research question and develop an analytical framework. The research question decides your eligibility criteria and your search strategy and everything from that point onwards. So it's very, very important. Well-framed research questions inform the process of conducting a systematic review. The type of question determines the appropriate type of evidence to address it. So appropriate type of evidence, we mean, what type of study design you should be looking for to address that research question. And you may have heard of PICO framework, describes the components of answerable questions for systematic reviews. So PICO is the acronym for population, intervention, comparison, and outcome. And we will go through a lot of examples to really, sort of pull them apart and then put them together. And that's what you're going to do during the group exercise session as well. So I will start by describing some general considerations and then the steps in framing a research question, including the PICO framework, and then decide on the question type and then the types of evidence to look for. And then we're going to wrap up by reviewing an example of a research question. As I said, well-framed questions determine the criteria used to select studies, right? You can use that to develop the search strategy, and that also determines the type of data you will be collected from those included studies. Here are, again, some examples of pretty well-framed question, and every single one of them, there are multiple systematic reviews. So the first one is completing root canal treatment in a single visit as effective and safe as completing the treatment over multiple visits. And I have to say, my experience with a dentist, 5 years ago, 10 years ago, it's always multiple visits. And actually this systematic review shows you could just complete the root canal treatment in 1 visit. It doesn't increase any risk, and it's just as effective as completing them in multiple treatments. So here the populations, obviously, individuals with the root, individuals with the dental problems, and then the intervention is 1 visit, a single visit. The comparison intervention is multiple visits, and the outcomes, we can talk about that. The second research question is intensive glycemic control, and we define the intensity there. More effective than conventional glycemic control for reducing mortality and cardiovascular disease in patients with type 2 diabetes. So the population is patients with type 2 diabetes. The outcomes of interest are mortality and cardiovascular disease. And you can figure out the intervention and comparison. The last research question is fluid restriction effective for treating heart failure patients. So the outcome here is mortality, although it's not specifically defined here. So systematic reviews can be used to answer broad questions versus narrow questions. So broad questions could be as broad as what are the comparative effectiveness of interventions for diabetes, right? And you can imagine there are so many of them. Another example could be what are the interventions available, or what are the comparative effectiveness of interventions for glaucoma? There are eye drops, there are laser therapies, there are surgical therapies. So you could narrow down a little bit by saying, what are the comparative effectiveness of topical eye drops for glaucoma? And then just winning that question, there are 5 different classes of jobs and more than 15 types of different jobs. So again, so your question can be very broad, it can be comprehensive. You can use that question, broad question, to explore the consistency or inconsistency amongst the results, right? So that relates to the homogeneity and heterogeneity we spent some time talking previously. But it requires more resource, right? As broad as the question is, you will include many more studies, and it's quite complex and unwieldy most of the time, and the interpretation may be challenging unless you have very pre-specified groups of studies you want to analyze separately. In comparison, for a narrow question, they're usually more manageable, right? You know, if you frame the question so narrow, you know, what is the effectiveness of, you know, N95 mask compared with the surgical mask amongst the healthcare workers during the COVID-19 pandemic is relatively more narrow than the question we started with. It was easier to read, evidence may be sparse, there might be limited applicability, it may result in spurious conclusions, and increase the burden for accessing and summarizing multiple reviews. So when your question is pretty narrow, you may have multiple reviews on the same question, and then you need to summarize all of them together. So now moving on to the steps in framing the question. So let's start with the PICO framework. And then the second step is, what is the question type? Here are some examples. Infant with severe eczema. So if you're interested in what is the cause of this condition, is that because of environmental exposure? That addresses etiology. That addresses the causes for a condition. It's a question about etiology. Whereas if you're interested in knowing the likelihood of getting better or getting worse when you have this condition, it's about the prognosis, right? It's about the prognosis of a disease or a condition. What is the potential benefits of topical corticosteroids? That's about the effectiveness of therapy. You might be also interested in knowing the potential harms of topical corticosteroids. That's about the harm of intervention. There are potential differences in outcomes if the patient is treated earlier than later. So again, that's about therapy and prognosis. So even among the population infant with severe eczema, you can imagine you could frame the question very differently, and they all answer different, addresses different problems. So here on this slide, on the left-hand side, you see the question that people may ask. And on the right-hand side, we classify the question by question type. So the first two, what the proportion of population is newly diagnosed with this problem each year, because that talks about the newly diagnosed cases, is about the incidence of a condition. What proportion of the population is currently living this problem? So that's about the prevalence. So those are the two questions about really the disease burden. You know, what should be done to treat this problem? That's about therapy. Well, detecting this problem early before symptoms make a difference in my health. So that's about screening and prognosis. How good is this test at detecting this problem? So that's about diagnostic test accuracy. What is the likelihood of the likely outcome of this problem? Again, that's about prognosis. Will there be any negative effects of an intervention? That's about harm. What causes this problem? That's etiology. How can this problem be prevented? That's prevention. So those are the questions and how we classify them. Now let's put those questions, you know, with some real examples. Is treatment with the remdesivir more effective than placebo in reducing severity of COVID-19? So that's about the therapies. That's about effects of a particular drug. And what is the incidence prevalence of COVID-19 in Rhode Island? So that's about incidence and prevalence disease burden. Compare with pulmonologists, how effective are primary care doctors in detecting COVID-19? So I'm going to ask John to bring out the poll question. What type of question is this? Compare with pulmonologists, how effective are primary care doctors in detecting COVID-19? Okay, so is that about screening? Is that about prognosis? Is that about diagnostic accuracy, or is that about prevention? Okay, we have a poll question showing on your screen, and we would like to see there are 30 plus of you in the room. We should get more answers than only one, okay? All right. Did you get a chance to answer that poll question? And we may ask John to share the results with all of us. So I think 52% of you got it right. So this is about diagnostic accuracy, right? It's not about screening, because this is really comparing two different types of healthcare professionals in detecting a condition, right? So pulmonologist versus primary care in detecting COVID-19. So it's about who is more accurate in diagnosing a disease. It's about diagnostic accuracy. We do have some examples about screening. So I will go through this list with you. The next question, what is the probability that an otherwise healthy 40 years old with COVID-19 will need a ventilator in the next 2 weeks? That's about prognosis. So the next question is about screening. Is screening for symptoms outside grocery stores effective in identifying COVID-19? So that's about the screening program, right? Think about the screening effectiveness. What proportion of patients receiving remdesivir for COVID-19 develop liver damage? That's about harm. Is hypertension a risk factor for the development of COVID-19 in adults? That's about etiology. And I don't think I have COVID-19. How might I best protect myself? That's about prevention. So, when you're working in the healthcare field or any other field, you may have all these different questions, either asked by your patients or come up during your research. And then the first step, if you're thinking about doing a systematic reviews about this question, is really to, think about classify them. Is it about therapy? Is it about diagnostic test accuracy, about burden of disease, or what? And the reason for that step, why it's so critical, it is because the classification of the question will determine the appropriate types of evidence to look for. So for questions about prevalence and incidence or disease burden, we rely on cohort studies, cross-sectional studies. For therapies, screening, diagnostic test accuracy, prognosis, we rely on clinical trials and cohort studies. And for harms of intervention, we rely on cohort studies, trials, and cross-sectional studies. And for etiology, mostly are cohort and case control studies. There won't be trials for you to study etiology, okay? So the components of an answerable clinical question, as I mentioned earlier, the PICO really stands for the populations, the interventions, the comparison groups, and the outcomes, okay? When you're defining the population, think about the condition or the disease you're interested in studying, including how they will be diagnosed, right? Because the diagnostic criteria, for example, as simple as for hypertension, has changed over the past 2 decades. So when you're saying, we're interested in patients with hypertension, are you going to accept any definition being used in the primary study, or you will only be accepting the studies use the current modern definition? And also think about the population and setting of the interest, the age group, the sex, and comorbidities, whether this is a community setting, hospital, or outpatient. So the population, as simple as P, really covers all these considerations. In terms of intervention, think about the mode of delivery, including personnel who is delivering it, right? The dosage and intensity, the duration and timing of the therapy, as well as co-intervention. So most of these would apply very well to a drug therapy, where you can imagine the different concentration of the drug, different duration of use will have quite different results in terms of effects. So specifying all these intervention elements will be very important in predetermining what studies you would be eligible for your research. And comparators, there's no treatment, placebo, standard therapy, or active treatment. So when you're comparing 2 active treatment, we call those head-to-head comparisons. So there's a question in the chat whether meta-analysis, whether population could just be adults for meta-analysis. So you can imagine if the topic is only for the adults, you can definitely narrow it down for the adults population, right? And if the topic like retinopathy or prematurity is only applicable to newborns, and you would only include newborns rather than adults. And the outcome, so is the measures or events used to determine whether an intervention is effective and or safe. If you're familiar with the regression analysis in statistics, those are your dependent variables, and it's a yardstick for you to quantify the effects of exposure. There are 5 elements to completely specify an outcome. And this is very important because when you say, hey, I'm interested in anxiety, that's not precise enough for a systematic review or for any primary research. This is because anxiety can be measured using many different instruments. The Hamilton Anxiety Rating Scale is one measure that we can use to measure anxiety. And then what about, the specific metric? Are we talking about anxiety at 6 months, or are we talking about anxiety, change in anxiety from the baseline? So you could think of a change score, or it could be a continuous measure, or it could even be a binary outcome. Has your anxiety improved over time, right? That's a yes or no question. So you have to think about the specific metric in measure that outcome domain. And then the next level is the method of aggregation. Are we talking about mean? Are we talking about mean change from baseline, or is that a median change from baseline? The last element is the time point, is the anxiety measured on Hamilton Anxiety Rating Scale in terms of change from baseline, mean change from baseline at 6 months or at 12 months. The reason to completely specify these outcomes is because any change, other than the domain, any change in any of these elements is going to give you a different result. So the result goes into your meta-analysis. If you don't fully specify these, imagine there are multiple results for you to choose from. There could be a 6-month result and 3-month result for you to choose from, which one to pick, right? So that gives, leaves room for biased analysis, where your prior belief and hypothesis may decide which result you're going to use for meta-analysis. That's undesirable. That should be avoided by pre-specifying all these elements for an outcome. Another example being visual acuity, visual acuity being measured using the logMAR chart. It's a value at a time point. We're looking at mean change at 3 months. So these are the 5 domains, 5 elements of a completely pre-specified outcome. And one of you want me to go back to the last slide. Can you ask your question?
I was just trying to see what it said. I didn't get a chance to finish writing it down.
Okay, you should be able to download the PDF of the slides from the course website. All right. So now let's review an example of a research question. So in 2000, the American Academy of Pediatrics recommended that children at high risk for food allergies should avoid peanut consumption until age 3. So this was 22 years ago when they made this recommendation. However, the incidence of peanut allergy more than doubled between 2000 and 2008. So in 8 years' time, the incidence of peanut allergy in this population doubled, increasing to nearly 2%. So in 2008, the recommendations for the avoidance of allergens were withdrawn. So the scientific rationale are the gut is the largest immune organ in the body. Experts now hypothesize that early introduction of high allergenic foods might be the key to producing tolerance. So there were several trials done on this topic, and then a systematic review to summarize this, the results from these trials. So who are the first the first element of the PICO is the population. So who are the relevant patient groups? Define the condition or disease, including the explicit diagnostic criteria and population and setting of the interest. So it's infants less than 12 months of age with severe eczema, egg allergy, or both. That's the first part of the question. For infants less than 12 months of age with severe eczema, egg allergy, or both. And what is the intervention risk factor of exposure of interest? In this example is the consumption of peanuts, right? That's consumption of peanuts. And then the next component, comparison. When compared with avoidance of peanuts. And then the outcomes of interest are the presence of peanut allergy at 5 years of age as measured by oral food challenge test, or as measured by immune markers. So the last part of the question, the outcome would be prevent peanut allergy at 5 years of age as measured by oral fluid challenge test and immune markers. So when you put these components together, that's your research question. For infants less than 12 months of age with the severe eczema, an egg allergy or both, does consumption of peanuts when compared with avoidance of peanuts prevent peanut allergy at 5 years of age as measured by oral fluid challenge test and immune markers. So that's what I mean by a fully specified research question. So now I'm going to ask you, what is the question type? Remember the question type? Let's go back to the slides about question type. All right, here. So can you tell me the question type? Someone said etiology.
Can you go to the question again, please?
Okay. Well, you can go back to this slide. Well, let me share the screen again. I need to go outside of the full screen mode. Oh, you cannot see it yet. All right, so here's our question. For infants less than, so the first part is about population, right? The last part is about your outcome. And now you have to really think about the intervention comparison and then decide on the research question type. Is that about prognosis? Is that about whether this will be better or worse? Is that about disease burden? It's not about disease burden, right? Is it about diagnostic test accuracy? No. Is it about screening? No, right? Is it about prevention? No. So what is the question type? Harm. It's about harm. So it's about prevent. It's about reduce the peanut allergy at 5 years of age as measured by all of oral fluid challenge test and immune markers. So this is actually, any other thoughts? Prognosis, incidence. So I'm going to ask you guys to speak up why this is an incidence question. So incidence is about, the number of new cases in the population, right? So without any intervention, this is definitely not about the disease burden or the incidence of a condition in the population. So this is actually a question about therapy, right? About treatment, about intervention effectiveness. So the intervention is consumption of peanuts, and then the comparison group is avoidance of peanuts. And you can actually test that out in a randomized controlled trial setting, and there are multiple trials on this topic. So they randomized infants, sort of that fulfill this eligibility criteria to the consumption of peanuts versus avoidance of peanuts, and then they measure the outcome at 5 years old, right? So that's a question about intervention or therapy. So did I confuse all of you? So you can actually design a trial, and there are many trials on this topic. So the intervention is, so basically you're randomized a group of individuals into two intervention groups. One group is being told to consume peanuts, and the other group is being told to avoid peanuts consumption, okay? And then you follow them for 5 years and compare the results. So it's a typical setup for a randomized controlled trial, and you can compare the effect of intervention. The intervention is the consumption of peanuts, and then the comparison group is avoidance of peanuts.
Okay,
Yeah.
so
this is the peanuts intervention trial, yeah.
So can you say, so when you're looking at another scenario using face masks and COVID as an example, so when we say does use of face masks when compared to non-use of face masks prevent COVID infection, would you say it's a therapy? Yeah,
I would say it's, so it's a question about effects of intervention, right? And in that particular case, you may have both randomized controlled trials as well as observational data to answer that research question. And then if you step, a little bit behind, above, at the primary studies level, when you're doing a systematic review, you have to decide whether you want to include both randomized controlled trials and observational studies for that research question. So that's something as a systematic reviewer, you need to decide. Okay. However, if you just look at the question type itself, is really about effects of an intervention, right? Effects of, what types of masks prevent the transmission. So could it just be observational rather than RCT for peanut example? The answer is yes, right? There are plenty of observational data on this topic as well, right? So the observational design versus trial design is the design for the primary study. And what we're trying to classify, you can use observational studies to answer the question about effects of intervention. Although observational studies are susceptible to selection bias and confounding, and all those things inherent in the study design. And we'll talk about those things tomorrow when we're assessing the risk of bias. So observational studies and like cohort studies or case control studies can be used to answer the question on the effects of intervention. They're just more susceptible to biases compared with the well-designed and conducted randomized control trials, right? So someone has a question about the ethical issues. The ethical issues for these, so that you can read the trial, and this was actually a trial of the year by the Society for Clinical Trials. The ethic issue is we really don't know. There's equipoise of this question, and the background I showed you was, we thought it was a good idea to keep kids or infants away from peanuts, but actually it did not do any good, but more harms, because the incidence has increased, doubled from 2000 to 2008. So there's enough of populational level data, as well as lab-based data to suggest giving them peanut may not be a bad idea. So the equipoise for the trial still holds, and then they tested this out in a randomized controlled trial setting. All right, so in summary, well-framed research questions inform the process of conducting a systematic review. The PICO describes the components of answerable questions for systematic review. And then the types of question is very important for you to classify, because that will determine the appropriate type of evidence to address it. And for most of these questions, you may have more than one type of evidence, like trial evidence, as well as cohort studies or observational studies. Again, as a systematic reviewer, you need to decide whether you're going to broaden your eligibility criteria by including both trial evidence and non-trial evidence for example, the questions on effects of intervention. And for questions on effects of intervention, my recommendation would be when you have quite a few randomized controlled trials, it may be a good idea to stick to randomized controlled trials rather than broaden your criteria to include observational studies. Again, just because of the control for biases, observational studies have very limited approaches in terms of controlling the biases, and we can talk about how to assess risk of bias for observational studies. So that is, this section is pretty quick, and we're going to get you to work on some real examples. So I don't know if Riyadh is here yet. Probably not. So why don't we do this? Take a quick biology break for 5 minutes and come back. Make sure you have that, let me show you what it does it look like in a minute. So this is what this is the exercise, what it looks like. Okay. The agency for healthcare research and quality runs these effective healthcare programs. That program supported the evidence-based practice centers in the US. And if you go to this website, they actually have a form for the general public to nominate research questions for systematic reviews. So any of you could just go there and nominate a question. And we went there and downloaded some of the questions nominated by the public, right? So most of the time, the public these are just ramblings around an idea. And what we're going to ask you to do is to rephrase these questions using the PICO format, and so that they're specific, so that they can be addressed in a systematic review. And there are 3 sets of questions, okay? And we will be sending you to 3 rooms, like 2 breakout rooms plus the main room. And in each room, there will be a facilitator, and I will be staying in the main room. And what you're going to do is you're going to turn on your mic and discuss with your group members basically what are the population intervention comparison and outcomes. Can we rephrase this question so that it's more specific? Okay, so make sure that you have access to this document, and we're going to take there's a question. Okay, just sending the link to get access to this document. So take a break and come back at 25 past the hour, and then we will be sending you into breakout rooms, and then you will be working on these questions for about 15 to 20 minutes, and then we will bring you back to the main room. We're going to ask you from each of the group to report on one of the 2 questions assigned to you. So tell us a little bit about your thought process in rephrasing that, and what will be the well-defined research question be after the discussion, and any uncertainties you have or any sort of discussion points that your group had would be really, really helpful and interesting for the bigger group to hear. So go to take a break, and we'll be back 25 after the hour, and we will be sending you straight to breakout rooms and work on these, and then bring you back maybe 10 or 15 minutes towards the end of the today's session. All right.
Hello all, my name is Professor Riaz Qureshi. I'm an assistant professor here at the University of Colorado Anschutz Medical Campus in the Department of Ophthalmology. And I've worked with Cochrane Eyes and Vision for several years now. And yeah, happy to be here.
Right, thank you so much, Riaz, for joining us and facilitate the small group discussion. So make sure you have access to this document, okay? And I saw that you might be able to find the link in the chat. And I'm going to ask to divide people up. Basically, I will be in the main room leading the first set of questions, and John will be in the breakout room, the first breakout room, and it will be whoever in that room will be discussing the second set of questions, and Riaz will be working with you on the last set in the second breakout room. So please speak up. This is your opportunity to chime in. So our group, we decided to report on the second question, and I'm just going to read this essay, the submission by a general public individual. Which interventions prevented, which ones just delay falls in the elderly? Many studies show short-term gains in timed up and go and other intermediate measures, and some show short-term reductions in emergency room use and fractures. But what is unclear is whether these gains mostly just delay instability. Perhaps the better interventions lie in environmental modifications to reduce risk of falls and harms from falls. All right, so I'm going to ask the reporter from my group to rephrase this into an answerable research question.
Hi everyone. So I will be talking on the our probably our research thoughts during the process of trying to figure out a research question for this. And while going through the number 2, we found out that the population there, using the PICO format, the population there is the elderly, and we defined the elderly as ages from 65 years and above.
Mm-hmm.
And we also found out that while looking at it, we looked at what the intervention could be, and we are looking at the environmental modifications and as a proposed intervention in this question. And what we are looking at as environmental modifications are, so when we're talking about environmental, we mean those things in the environment that would aid fall or that would prevent fall of the elderly, like caregiver walkways, pavements, rails, and caregivers and mechanical workers and what have you. So what we are proposing as an intervention there is we are proposing using mechanical workers, and we are comparing it to use of medications. So all the calcium component drugs that aid strong bones in the elderly. So we are comparing it to determine or to say which would lead to a better outcome. And our proposed outcome from this question is fracture. We are looking at fracture because there are various outcomes that you can get from this. There are fracture is there, mortality is there, or just strain and what have you. But we chose fracture as the outcome we'll be looking into in this particular question. Yeah.
Thank you so much. Any other team members want to chime in? All right, so this is a very broad question, right? Like environmental modification, there's so many of them, and the comparison was never specified in the essay. So you have to think about what would be the interesting comparisons to you. And in terms of the outcomes, even if you narrow down to fractures, there are vertebral fracture, non-vertebral fracture, hip fracture, you know, all sorts of combination of fractures. So again, think about what types of fracture. And what we haven't talked about is really the setting, right? Are we talking about people living in a community, living in a assisted living situation, or and also the timing, you know, how long will any of these environmental modifications going to have an effect in reducing the falls? So those are the sort of the components of research question. And given the time constraints, I'm going to move on to the second set. So John, your group, which one do you want them to work on?
Yeah, they worked on number 1.
Yeah.
So Lawrence, you want to present
sir.
your report?
So the questions, or number 1 states, we are interested in the health benefits of very low carbohydrate ketogenic diets as therapy for disease prevention, reversal, and health promotion. We would like to know, ketogenic eating is beneficial as adjunct therapy in more advanced disease states. We would like an honest, unbiased review of the robust literature surrounding nutritional ketosis. So what we did was we decided that based on the PICO system, we first decided that our population would be African-American people with metabolic syndromes aged 25 to 65 and The reason why we kind of picked that age group was because that would be a good indicator of at least above the age of 25 is where we start to kind of see the disease really start to show up. And above 65, it's almost inevitable that you're going to have a metabolic syndrome just due to time, such as sarcopenia, heart disease, low movement, and other issues.
Yeah.
For our intervention, we decided that it would be low carbohydrate ketogenic diet based upon the question. And we would compare it to a Mediterranean diet, which is just another type of diet that is typically deemed as popular and potentially beneficial. And then we decided that our outcome, which would be our measures or events used to determine whether an intervention is effective and or safe, would be A1C levels for type 2 diabetes, cholesterol levels and triglyceride levels, which are usually associated with heart disease, and then BMI, which is a good indicator as well as other diseases, including obesity, which leads to multiple diseases as well.
Yeah. So may I ask, for your population, are you going to look in a general healthy population without any baseline comorbidities?
That's a great question.
Yeah, because when you mention all those outcomes, as you can imagine, if your research question is restricted to patients with type 2 diabetes, you definitely want to measure all type 2 diabetes related outcomes, as well as, like the weight, BMI, and all of that, right? So think about your population. Again, I think at least this question is slightly better framed when they submit it.
There's also their specification as an adjunct therapy, right? So they actually aren't interested in its effect on its own, but as an adjunct. So considering what kinds of things you'd want to pair that with in your question.
Yeah. But okay, Riaz, do you want to move on to your question and then we can summarize?
Yeah, so I'm not sure who from my group would like to speak up, but we looked at number 1, which was quite broad, and seemed to, well, I'll let my group members suggest, talk about what it seemed to suggest they were interested in.
I'm happy to come in there. I'm Pravina from UK, actually. Nice to come on to this course. So what we talked about is the medication adherence, and we looked at the population group, and we decided that we would go with people with chronic disease who have comorbidities and who take at least one medication, so that there is a medication adherence, because you're looking at a medication. So people with chronic disease, you have comorbidities and take at least one medication. The intervention would be medication adherence with help of a peer navigator or full con reminder, text message, something like that, which help the patient. So it's a medication adherence is the intervention, but with some support, with either a phone call or a reminder or text message. And the outcome would be episode of hospitalizations. Time period is 6 months, and the comparator would be medication adherence without any support. Somebody can chip in, but that's what I thought. Riaz, you can correct me if you can.
Yeah, I think so. We talked about how the question really sort of specifies what are the best practices in general. And we decided to keep that broad and look at all different possible interventions. There's lots of different ways to improve adherence as the primary outcome, and compare them against each other. So instead of comparing all the interventions individually against no intervention, we talked about how, in spirit of the question and their interest in what's best overall, it would be most appropriate to actually compare everything against everything else, sort of taking a network approach in these interventions. And that comparison then, adherence is what they talked about for improving. So adherence would also be the outcome. And we sort of thought about different ways to measure that. And we sort of went with sort of prescription refills sort of over as with expected prescription refills. So are people actually filling them as they should be?
Yeah.
Yeah, so I found that this was really difficult, and I think the group might have thought that as well, because we're trying to interpret what somebody else wants us to answer and to develop a research question based on their overall idea. And so that's why we decided to
Yeah.
But in chronic diseases as opposed to one of them, because we felt that that person might have thought there was something in common about those chronic diseases, you know, and that being whether they stay, regardless of what that is, whether they stayed in keeping with taking their medication, and the intervention would then be, you know, having somebody come in to either call them or remind them. And then the outcome would be their lab numbers, you know, like objective lab numbers improving or not, you know, regardless of what the disease was, you know? Yeah. And so it takes a lot, I think, to wrap your mind around the spirit of the question, you know, and we spent a lot of time discussing that.
Thank you so much for that insight. I think you summarized this really well. It really took a lot of effort to get your head around and trying to get the spirit of the questions. And imagine, you know, if you're working at the effective healthcare program, you have to shuffle through all these questions submitted by the public, because as a public, a suggestion, you have to write a justification on why you're not moving forward for even every single one of them. So it's not an easy job. And actually very few of them can be reframed into a reasonable question that can be addressed in a systematic review. And I think the second thing that jumped out from all these three examples is your research question for systematic reviews can be broad or can be narrower, right? It can be broader or narrower. And you have to decide, you know, whether you want to answer a broad question. And usually, even within a broad question, you will have to think about subgroups of comparisons to look at, or different patient groups. You know, for example, the second question, you can imagine that could be in patients with diabetes, with hypertension. There are all different subgroups of patients to look at. So you know, there are benefit of doing a broader review, you know, answer a broader question, but again, it just requires more resources and time investment. And the last point I would like to make is your research question for systematic review are typically broader than the question that being addressed in a primary study, right? The primary study will be comparing home modification versus exercise for two hours every week. You know, it's very specific, but you cannot frame a question as specific as that for your systematic review, because you may not end up with any studies or end up with one study. So your systematic review research questions are typically broader than those can be addressed in a primary study. So I hope those are the take-home messages. Okay, I'm going to stop share. We're at the hour. I just want to remind you very quickly about what you need to do today before you come in tomorrow. So I encourage you to watch this Searching for Trials lecture, because I'm not going to talk about them, and they're critically important for any systematic review. They're about 5 to 10 minutes for each part. So altogether, you will be watching something under 30 minutes. And I strongly encourage you to do that. And when we come back tomorrow, it will be quite heavy because we're going to talk about risk of bias. So if you need a refresher about the types of bias, just Google selection bias, confounding, and information bias, or just dig out one of your EP 101 book. And then we'll talk about meta-analysis. You have seen enough forest plots today, but we will dive a little bit deeper into how those forest plots were put together and how to interpret the estimates for statistical heterogeneity. All right, so I will let you go and see you tomorrow. Thank you so much for your participation.
Hold on before you go. Again, as I said and indicated, if you need a certificate of participation, you have to sign the sign-in link there, and also you have to be here for come to the section both days to get the certificate of participation. So we'll reconvene here again tomorrow, same time at 10:30 a.m. Eastern Standard Time. So we'll see you all tomorrow, unless you have any questions.
I do. You said a sign-in. Where's the sign-in?
If you look at the chat room, I think it was the first post that was posted there in the chat area. I think it was done throughout also. Otherwise, you can go to Slack.
Yeah. And otherwise, I'm going to stay here for 5 more minutes. If you have questions you want to stay on, I can answer your question. There's a question in the chat about, can you include a systematic review as part of your systematic review? The answer is yes. And that is called like overview of systematic review. So basically you're summarizing systematic review, a bunch of systematic reviews. And even for a conventional typical systematic review, we also use other systematic reviews in the background, in the discussion, to talk about similarities and differences between your findings with other people's findings. So the answer is yes. Okay, so yeah, so
Can
I
they
will
be
be here.
mixed? Can they be mixed with primary research? Can you do a systematic review and a
Not
primary?
really, because you can use systematic reviews to identify studies they included you may have missed, right? But the unit of analysis is still at the individual primary study level for a typical systematic review. And for overviews of systematic reviews, the unit of analysis is individual systematic review. So we don't do mix and match, but definitely systematic reviews are very informative for different reasons.
How do you put that there? I don't know. I just don't know where to keep running. So you don't have a panty liner?
All right. Well, so thank you for your participation. If there are no other questions, I'm going to sign off. I will see you tomorrow morning, and feel free to send me emails if you have questions coming up later once you get a chance to reflect on the materials we have covered. All right. Bye,
Okay, so those wanting to sign in, I see someone say they can't find the link. The link has been just posted maybe in 2 minutes ago in the chat area. You click on it, then you can sign in for attendance.
Sorry, my name is Dr. Warren. My computer does not support this, and I discussed that in my group.
Yes, I'm saying use the Slack, the web browser, the browser version. Don't download the app. Just go to Slack website and just sign in. You should be fine.
Okay, I'll try. If not, I'll let you know tomorrow.
Yes, let us know. Let me put my email here, and anything, just send me an email.
Okay. Thank you.
All righty.